We'll go ahead. Okay. All right. So welcome to this webinar. Our topic for today is diabetes and diabetic ketoacidosis and HHS, the complications that are associated with diabetes. But I must begin my presentation with a question, because this question is going to lay a foundation on where you are and for me to be able to gauge whether or not I need to do something else. So let's go ahead and do this poll. Okay, so that was the old paradigm that diabetic ketoacidosis occurs only in type 1 diabetes. It actually occurs in either type 1 or both type 1 and type 2. So at the onset, I wanted to make sure that you remove the old learnings that you had, that DKA is only a complication of type 1 and HHS is a complication of type 2. That is no longer true, as evidence have shown us. So we're going to begin our discussion with the complications of diabetes, and that is diabetic ketoacidosis. This is a major life-threatening complication of diabetes and is characterized by three things: hyperglycemia, which means to say that there's a lot of glucose in the blood; ketoacidosis, which means to say that there's a lot of ketone bodies in the blood as well; and ketonuria, the evidence or the elimination of ketones via the urine. So this occurs when there's no insulin, and it inhibits the ability of glucose to enter cells for utilization as a metabolic fuel. And the result then is that the liver rapidly breaks down into ketones to employ fuel source. So let me just illustrate that in here. All right. So when this is a cell, usually what we use for fuel is going to be glucose. And the offshoot of glucose is going to be carbon dioxide, water, and heat. So these are the things that are going to be disposed of as a result of metabolic activity with glucose as a fuel. However, when we have a diabetic ketoacidosis, what's going to happen because of the lack of insulin is now the body is going to utilize fat as a fuel. And when fat is utilized as a fuel, it's an alternative fuel. The offshoot, however, is the production of ketones. And this ketones is not easily excreted by the body. And that is the reason why the overproduction of ketones causes them to accumulate in the blood, in the urine, and turns the blood as an acid. So it mainly occurs in patients with type 1 diabetes, but it's not uncommon actually to see it in patients with type 2 diabetes. And that is the reason why I did start with that poll, to emphasize the fact that it can happen in both diabetes type 1 and type 2. Okay, so diabetic ketoacidosis is going to occur as a result of an absolute or relative lack of insulin. And this type of hormonal imbalance is going to enhance the breakdown of glucose in the form of glycogen as well as fat. And what happens with lipolysis, or the breakdown of fat, there's going to be an increase in free fatty acids. So free fatty acids are the ones that are utilized as an alternative energy source. This results in the accumulation of metabolites, and those metabolites includes ketones. And therefore, that's what ketoacidosis is going to occur. Now, as a result of this, there's going to be acidosis. So when you have acidosis, what happens to the potassium as well as the sodium? Well, it's going to be displaced. Okay, so you normally, when we have a cell, and again, it does not seem to cooperate with me. When we have a cell right here, potassium is actually the intracellular fluid, electrolyte that is going to be abundant. And then, of course, sodium is going to be on the outside. All right, now when we have acidosis, what's going to happen is hydrogen is going to come over here and kicks out potassium. So potassium is going to go out of the cell as an exchange, and it goes to the extracellular space. So when we have a shift of potassium from the intracellular to the extracellular space, then what's going to happen is that there's going to be potassium abnormality that you will notice in the event of acidosis. So always think about that in acidosis, potassium goes out, and therefore you will have initially hyperkalemia. Okay, so in answer to the question, what happens to serum potassium and why? The answer to that is that there's going to be a shift of potassium from the intracellular space to the extracellular compartment. So this is a very important concept to behold, because when you are trying to treat diabetic ketoacidosis or any acidotic state, hyperkalemia is going to be initially observed. Okay? All right. So when we look at diabetic ketoacidosis, as far as its pathophysiology, it begins with hyperglycemia. And with hyperglycemia, there's going to be an increase in plasma osmolarity. And with the increase in plasma osmolarity, we're now going to have intracellular dehydration. So I'm now going to, again, illustrate what happens whenever we have an abundance of glucose in the bloodstream. So if this were a cell, and maybe it contains a few glucose, but now this is the blood vessel, and it contains a lot of glucose. So what happens is it becomes more osmotic. And when we say it's going to be more osmotic, it's going to attract fluid to it. And so with hyperglycemia, what's going to happen is it's going to draw all the fluid into this vascular space. So the fluid will now move from the intracellular compartment to the extracellular compartment. And that is why in severe hyperglycemia, what you're going to have is that you're going to have intracellular dehydration. Okay, so I hope that this is clear so far. And now let's go further. What happens when there's plasma osmolarity that's going to be increased? So again, if I were to illustrate the blood vessel, and now the blood vessel is full of glucose, the water or the fluid is now going to come over into this vascular space. It expands the extracellular compartment or the vascular bed. So when you have a lot of fluid in your vascular bed, what happens to your urinary output? It certainly is going to go high because you now have an increase in your GFR or glomerular filtration rate. And so it results in diuresis, okay? So now the diuresis is now eventually going to create a loss of your electrolytes, your sodium, your potassium, your phosphate, and your magnesium. So do you remember at the outset I said that with acidosis, what's going to happen is that initially potassium is going to be high. But then once diuresis occurs, you're now going to lose the potassium, and therefore eventually you will have hypokalemia. So hyperkalemia occurs first, and then it's going to result in hypokalemia. Okay? So with the diuresis, the profound diuresis that occurs, it results in a decrease in your extracellular fluid volume, which therefore results in shock. The decrease in glomerular filtration rate causes acidosis. And again, because of the stress response, you're going to increase your glucose as a result of the stress response. And then, of course, azotemia, or an increase in BUN. So this is the pathophysiology of diabetic ketoacidosis. And so let's take a look at the causes of diabetic ketoacidosis. I told you that it can occur in diabetes mellitus type 2, but it mainly occurs in diabetes type 1. 10 to 30% of the cases occurs in patients with type 2. So always remember that caveat, that DKA can occur in both type 1 and in type 2 diabetes mellitus. So some of the most common risk factors that are associated with the precipitation or the development of extreme hyperglycemia and subsequent ketoacidosis are going to be infection. Concomitant infection is commonly an inciting factor in DKA. So the patient might be treating themselves okay with anti-diabetic drugs, including insulin, but if they have an infection and they do not have an adjustment of their insulin dose or their anti-diabetic drugs, then this could result in diabetic ketoacidosis. So remember, it is the most common scenario for diabetic ketoacidosis. Secondly, if individuals are not going to adhere to their insulin therapy, such as missed or disrupted insulin treatments, this would also be a very common cause. And I would like to submit to you that the most common population that this is true in is actually adolescents. They usually forget to adhere to their insulin requirements. And that is why it's an emphasis supposed to be in your teaching in patients who are adolescent about adherence to insulin as well as anti-diabetic regimen. Now, the other thing that can happen is acute major illness or acute physiological stress. And when we say stress, we're not talking about emotional stress. Whenever we are stressed, there are a lot of catecholamines that are released. These are substances that are released from the adrenal gland in response to a physiologic stress. So what are going to be released would be your glucose, as well as your glucagon and catecholamines. And therefore, this could also precipitate, again, diabetic ketoacidosis. The other thing that could do this complication is going to be medications. There are certain medications such as glucocorticoids. And when I say glucocorticoids, that includes your steroids or even atypical antipsychotic agents, which has the potential to affect carbohydrate metabolism. So as you could see on top over here, the drugs that are usually associated with them are your antipsychotic drugs, like your clozapine or clozaril or olanzapine or Zyprexa and risperidone or risperidol. So these are drugs that are commonly the culprits in causing ketoacidosis. And the other things are illicit drugs like cocaine and alcohol, steroids, glucagon, symptomimetic agents like epinephrine, and thiazide diuretics. So I want you to remember that thiazide diuretics, because this usually is a very common question in NCLEX. Okay, as one of the complications of the use of thiazide diuretics is hyperglycemia. All right, so these are the most common causes or precipitating factors for the development of diabetic ketoacidosis. So what are the signs and symptoms of diabetic ketoacidosis? So you remember there was a lot of diuresis. So what's going to happen is that it is going to stimulate the hypothalamus thirst reflex. And therefore, the patient will be having sensations of extreme thirst. And extreme thirst is going to be polydipsia. Poly meaning to say many, dipsia meaning to say the desire to drink. So patients with DKA will display or demonstrate polydipsia, as well as an increase in your urinary output, which is going to be polyuria. Now, there's also going to be sometimes vomiting, weakness, and mentation changes, and also dehydration symptoms. And so what are some of our dehydration symptoms? Well, this could include, for example, your mentation changes, a decrease in your ability to perspire, and the additional signs and symptoms of diabetic ketoacidosis is abdominal pain, which is a common complaint in patients with diabetic ketoacidosis. Okay, so you could look at the signs over here, and one of those signs that is going to be very characteristic in patients with ketoacidosis is going to be Kussmaul's breathing. And Kussmaul's breathing is an exaggeration of the expiration of the patient. Why is there going to be an exaggeration of the expiratory phase? To blow off acids in the form of carbon dioxide. So remember that Kussmaul's breathing is a compensatory mechanism to reduce acids in the body. And then, of course, there's going to be an acetone type breath, or ketotic breath, as they say. It's a sweet breath that you smell in these patients. And that's going to be one other classic sign and symptom of diabetic ketoacidosis. Okay, let's go to another poll. Okay, so I think I didn't emphasize it enough. Do you remember me saying that despite the fact that a patient might be compliant with their medication, but if they have an infection, infection requires an increase in your anti-diabetic agents. And so the correct answer here is letter C. An underlying concomitant infection is the most common cause of diabetic ketoacidosis. Because, like, for example, if I am taking insulin and I am very religious in taking my insulin, but I didn't know that when I get an infection that I need to adjust my dose, then I certainly will develop diabetic ketoacidosis. Okay, so let's take a look at the physical examination presentation of these patients. On physical examination, most patients with ketoacidosis will present with features of hypovolemia, from the GI or renal loss, as well as electrolyte loss. And in severe cases, obviously, the patients may be hypotensive and could even be in frank shock. And they may have a rapid and deep respiratory effort as a compensatory mechanism, and that is known as Kussmaul's breathing. And they may also have a distinct fruity odor to their breath, mainly because of acetone reduction. So I think that we had talked about that. So what are some of the findings that you're going to be seeing in these patients? Well, tachycardia, dehydration or hypotension, as manifested by hypotension, tachypnea and Kussmaul's respirations, a fruity odor in the breath, abdominal tenderness may resemble acute pancreatitis, and lethargy, obtundation, cerebral edema, and possibly coma. So those are the presentations of a patient with diabetic ketoacidosis. Now, whenever we are looking at a patient with diabetic ketoacidosis, obviously we're going to have to evaluate their laboratories. And so what laboratories are we more interested in or most interested in? Remember that hyperglycemia is the typical finding at presentation with diabetic ketoacidosis, and therefore it is imperative that we monitor their plasma glucose. Okay, so their glucose levels are going to be elevated. Now, the other thing that is going to happen is that you will have an increase in ketones, and that is why it's called diabetic ketoacidosis, because ketone bodies are going to be present in the serum. And so biochemically, diabetic ketoacidosis is defined as an increase in the serum ketone concentration above 5 MEQs per liter. Okay, so that is imperative. The serum ketones must be elevated beyond 5 MEQs per liter. And there's what's known as an increase anion gap. And I will postpone that a little bit later on to talk about what an ion gap is. And there's going to be an increase in serum osmolarity. All right, so what is serum osmolarity? When we take a fluid and analyze how much particles are going to be in there, that is going to be what's known as osmolarity. So I said at the beginning that there's going to be a lot of glucose in your blood vessels, and therefore your serum osmolarity are going to be elevated. Okay, so first, you're going to have an increase in blood glucose. And then second, you will have the presence of ketone above 5 MEQs in your serum, as well as the presence of ketones in your urine, and then an increase in serum osmolarity. Now, other tests that would help us to identify whether or not there's an infection, for example, would be CBC with differential. And we could also try to look at the metabolic panel, because it might be useful to find out what the general state of that patient is. So that includes, for example, your BUN, creatinine, your electrolytes are very critical, ABG, blood culture, urinalysis, ECG, and chest X-ray. Obviously, the reasons why we're doing blood culture, your urinalysis, as well as chest X-ray, is to identify the potential infection sites that the patient may have. And so these are the diagnostic criteria for DKA. All right, so let's return to an ion gap, because whenever you have a patient with diabetic ketoacidosis, it's imperative that you monitor this laboratory test. Okay, so an ion gap is going to be elevated in this particular situation. So let's go back to what is this anion gap, okay? So because this is a very difficult concept for beginning nurses to understand. And so let's talk about the number of electrolytes in our body are going to be, or ions is going to be equal from positive ions to negative ions. Okay, so anions are called negative ions. So anions are negatively charged. And cations are positively charged. All right, so look at this. It has a minus right there. That means to say this is a cation. And look at this. This is a positive, like sodium, positive, potassium, positive, and so on. Those are cations. So I hope that you understand that first of all. Okay, so the difference between an anion and a cation. In order for homeostasis to occur in the body, there has got to be always an equal number of anions to cations. So I'm going to enlarge this. And if you could see, would you add all the cations over here? 142 plus 5 plus 5 plus 3. How much is that? What's the total of the cations in our body? Very good. It's 155, isn't it? Okay. So look at the right side of the slide. That's the anions, the negatively charged. What is the total of our negatively charged or our anions in the body? 25 plus 105 would be 130. And if you add all of these, it should be the same. Okay, so do you understand now that in the body, in order for it to be in equilibrium, there has got to be always an equal number of positively charged ions to the number of negatively charged ions. But I would like to draw your attention to these. These things right over here, these things over here that are not abundant, like potassium, calcium, magnesium, and over here, the hyperphosphate, the sulfate, the organic acids, and the proteins, these are very minimal. And therefore, we call them unmeasured cations and anions. So let me repeat that again. These things over here, because they are so negligible in number, they are called unmeasured cations and anions. So just looking at them, which one has more unmeasured ions? Is it the anions or the cations? Which one has more unmeasured anions? Is it, ions, is it the cations or the anions? Don't be bashful. The anions is more, isn't it? Okay. So, sorry about that. All right. So would you total this unmeasured cations here? It's 13, isn't it? All right. And how about this unmeasured anions over here? It's 6, 7, 9 plus that's 25, 35. Is that correct? total these. I want you to be active. I know how to total, but I want you also to do it. All right. So how many of these are there? 25. Okay. So we have more anions. 25 minus 13 is equal to 12, isn't it? So that means to say that the normal anion gap is going to be anywhere from 10 to 12 milliosmoles, depending on the method of our calculation. All right, so let me write this down. The anion gap is increased. So if there is an increase in anion gap, that means to say that we have acid retention. Okay, so therefore, this becomes the basis of us trying to determine whether or not the therapeutic interventions are getting better. So in a patient with DKA, for example, you might start with an anion gap of, let's say, 35. And as you are treating this particular patient with insulin, for example, and they begin to have an anion gap of 25, 20, 10, and so on, that means to say that the effectiveness of intervention has been achieved. So do you understand that now? That the way in which we measure whether the acidosis is much better is to utilize the anion gap. All right? How do we know if hyperglycemia is being treated? Well, we know that hyperglycemia is going to be treated like, for example, if you had a blood sugar of 400 and it's now going to come like this, 280, 120, and so on. That means to say that we are doing okay with our interventions. But you are not measuring the degree of acidosis. So for acidosis, what we use is the anion gap. And again, what is our target? The anion gap should come to around 10 to 12 milliosmoles, I should say. And this is going to be the normal level of your, or optimal level of your anion gap. All right, are there any questions about that? Because that's a little bit complicated. So how do you measure the effectiveness of therapy as far as glucose is concerned? Blood sugar. And that is the reason why in patients with diabetic ketoacidosis, you might have to do finger sticks for blood glucose every 30 minutes or every hour. But you also need to monitor the anion gap. What is the purpose of the anion gap? The purpose of the anion gap is to see whether or not acidosis is resolving. Okay, so that is an anion gap. Okay, so let's see. Let's go to this poll. Okay, so let me go back to the slide wherein I emphasize that what you have to have is the definition of diabetic ketoacidosis is a serum ketone above 5 MEQs. Please remember that right here. You see it? A serum ketone of more than 5 MEQs is the definition of diabetic ketoacidosis. and obviously a blood glucose level that's going to be above 200 milligrams per liter, per deciliter. Okay? All right. So what is the treatment?
Was the answer C or D?
It was C, I believe. Oh. Yeah, the one with 5 MEQs right here, more than 5 MEQs.
Oh, okay.
Yeah, that begins the definition of diabetic ketoacidosis. Okay?
Okay.
All right, so what is the treatment for patients who have DKA? Well, the treatment is we usually follow the acronym DKA. So what does that mean? Well, we deal with the dehydration first. And as far as dehydration is concerned, we're going to deal with the decrease in extracellular fluid compartment, and we give normal saline or Ringer's lactate. So this is going to be a very important part of treatment, because you remember that in ketoacidosis, there's going to be fluid loss. So correction of fluid loss makes the clinical picture clearer and, in fact, may correct the acidosis. The presence of even the mildest dehydration indicates that at least 3 liters of fluid has already been lost, and therefore we need to make sure that we resuscitate this patient with boluses and also with drips, as you could see right over here. And you don't need to memorize this, but just to understand that the way in which we deal with DKA or diabetic ketoacidosis is to correct the dehydration aggressively. And then once the serum reaches around 12 to 14 milliosmoles, then what we're going to have to do is we're going to we're going to switch it to D5 and W. And you're going to say, but Dr. Tom, this patient had a very, very high glucose. Why in the world would you give more dextrose once the patient's glucose is around 120 or 200 milligrams per deciliter? And the reason for that is we need to continue with metabolic activity. If we're depleting all the glucose, but by hydrating, what's going to happen is that the patient is going to again go back into producing more ketones. So that is the way that we would do it. And then the second, see, dehydration is the first thing. And the second thing that we need to do is to deal with the potassium. Okay. So you remember I said at the outset that whenever you have acidosis, what's going to happen is that your serum potassium levels are going to increase. So you see over here that in the event that they're going to be higher, what we're going to have is what we're going to do, is we're going to suspend insulin. Why is it that we are going to suspend insulin until we normalize the potassium levels? What does insulin do to potassium? Well, I'm going to illustrate it again. If this is the cell, and you are going to give insulin, insulin is going to pull glucose and bring it over here. And along with glucose, it's always going to pull potassium with it. So glucose is going to move into the cell, and you're going to have an entry of potassium into the cell as well. So what's going to happen to this potassium over here? What happens to the potassium over here in the vascular bed if you give insulin? It is going to go into the cell. So you will now have hypokalemia. Oh, where am I? Oh, okay. So you will have hypokalemia. All right. So with the administration of insulin, we're going to move potassium into the cell. So that's the reason why there is in red over here, no insulin until the potassium is greater than 3.3. Because otherwise, what you're going to do is you're going to move the potassium into the cell. So it is very tempting in NCLEX to answer this. A patient is admitted with diabetic ketoacidosis. After resuscitation with fluids, what would be the next therapeutic intervention? A, glucose, B, correct potassium. What would be the answer? What would be the answer?
Correct potassium.
Yes. Why would you want to correct the potassium first? Because if you are going to give glucose, the potassium levels are going to go up, down. So let me give you a scenario. Supposing the patient's potassium was 3.2 MEQs, okay? And now we give insulin. What is going to happen to our serum potassium? Will it become lower or higher if we give insulin?
Lower?
It will become lower because you remember, if you give insulin, the glucose is going to go into the cell and it pulls potassium along with it. So this 3.2 will become 2.8. What is the danger of having a low serum potassium? You will have arrhythmias, and the patient will not die from diabetic ketoacidosis, but he will die from arrhythmias and cardiac arrest. Okay, so always remember fluids and then correct the potassium. After you have corrected the potassium, then it's going to be glucose. It's going to be insulin. Okay. All right, as far as the fluids are concerned, we usually are going to use isotonic sodium chloride or Ringer's lactate. And once the patient is going to now be euvolemic, meaning to say that their blood pressure has now stabilized, and that is why their blood pressures are now normal, we now switch them to a 1/2 normal saline. So why do we give 1/2 normal saline? So let's go to the different kinds of solutions that we use, okay? So the first one is isotonic. The other solutions that we give are hypotonic, and the other one is called hypertonic. So give me an example of an isotonic solution. An isotonic solution would be normal saline, dextrose in water. Hypotonic solution would be 1/2 normal saline, for example. So it's hypotonic. And hypertonic will be D50. So let's talk about this tonic thing. All right, if we have 2 compartments over here, and this compartment has 2 particles, and this compartment has 2 particles, the movement of water is going to be equal. It will go in, go out, and go out that way. So when you're giving normal saline, for example, you're maintaining an equal exchange of fluid and electrolytes between cells. So this is isotonic. So when do we usually use isotonic solutions? When we don't want to feed the cell or dehydrate the cell, we just merely want to maintain vascular volume, we use isotonic solutions. All right, now let's say that I have over here 2 particles, and this one is my IV, and it only has 1 particle. Where does the water go when I give a hypotonic solution? From an area of lesser concentration, you remember, to an area of greater concentration. So the water is going to go into the cell. So hypotonic solutions is if you want to hydrate the cells. So in diabetic ketoacidosis, are your cells dehydrated?
Yes.
Yes. So therefore, that's why we want to give 1/2 normal saline in order to push the fluid into the cells. Okay. Now, the opposite is true. Supposing now that I have a solution, the cell over here, and it has 2 particles. But now what I'm going to do is to give an IV that contains many particles. Where is the fluid gonna go? Where's the fluid gonna go? It's going to go from the cell into the extracellular fluid compartment. So this is hypertonic, and therefore, in hypertonic solutions, you're going to dehydrate the cells. So when do we want to dehydrate the cells? Let's say now that you have an inflammation of the brain. You want to, if this is the brain, and the brain, is enclosed in a skull. So one way, if it is inflamed, is to remove some of the fluid from the brain. We give a hypertonic solution. An example of that would be D10W. It also would include mannitol, for example, are examples of hypertonic solution. Okay, so if you understood that, you now will understand why in the world we want to switch to 1/2 normal saline. What is the purpose of that 1/2 normal saline? To feed fluid into the cell, to hydrate the cell. Okay? All right. And as I said, when the blood sugar is now going to be between 200 to 250, what do we have to do? We now have to change the IV to dextrose with 1/2 normal saline. We add the dextrose in order to prevent hypoglycemia. Okay. So the treatment of DKA has 3 pillars: fluids, insulin, and electrolytes. But actually, electrolytes should be in the middle. But nonetheless, this is the way this thing is going to is presented. But just for you to remember the acronym DKA. That's the order of how you would intervene in patients with diabetic ketoacidosis. D for dehydration, K for the potassium, and then A for the acidosis. Okay, so let's take a look at this poll. Okay, you did good. All right. So the correct answer is letter B, Remember, when insulin is given, it helps take the potassium back into the cell, which will cause potassium blood levels to fall. So insulin therapy is only started if the patient's potassium level is going to be 3.3 or greater. Okay, so more on the management as far as insulin is concerned. We now are moving to the treatment for acidosis. And insulin is going to be the drug of choice in order to do this. So only short-acting insulin is used for the correction of hyperglycemia. Why don't we use subcutaneous insulin? Well, subcutaneous absorption of insulin is reduced in diabetic ketoacidosis because of the dehydration. Therefore, using the IV or the intravenous route is going to be the preferable route to administering insulin. All right, so the initial dose is a continuous IV insulin infusion using a pump. And if available, it usually is going to be started at a rate of 0.1 units per kilogram per hour. And this usually is going to be infused until the blood glucose is going to approximate around 180, and we start to decrease it. We don't want rapid decreases in blood glucose. Okay, so why don't we just give 100 units of insulin in order to bring this down? What's going to happen when you do that is you're going to cause the brain to swell. And therefore, this is going to be a bad thing to do. Okay? The other thing is, of course, hypoglycemia may develop rapidly if you overcorrect. And therefore, we always want to make sure that we are going to do it slowly. Okay, so I want you to, let me just write that down. Rapid decrease in blood sugar can cause cerebral edema. That is the reason why we have to do it slowly, okay, or gradually, I should say, in order to prevent the water rapidly going into the brain, which would cause cerebral edema. All right. So if the blood glucose levels falls below 200, this is not going to be good. Again, the reason why that is because of the fact that it causes cerebral edema. So if the blood glucose falls below 50, we actually have to give 10% of dextrose, and insulin is going to be continued. Okay, so those are the important things about that management. All right, how about the electrolyte correction? We said that the correction of the potassium is going to be very important. We understood already why potassium levels are high, and that is because of the shift of the potassium due to the acidosis and the lack of insulin. So for those of you who arrived late, I was talking about what happens with potassium whenever you're acidotic. Okay, so let's say that this is the cell. Normally, potassium is abundant intracellularly. But if you have acidosis, what's going to happen is hydrogen is going to come over here, and it will now kick out this potassium out into the extracellular compartment. And therefore, you will now have hyperkalemia in the beginning. Okay? So we need to monitor the serum potassium hourly, and we always have to, along with the fluid replacement, supplement it with potassium. Then the correction of acid-base balance. Do we give sodium bicarbonate to these patients? And the answer to that is no. We do not give sodium bicarbonate because merely giving the insulin will actually resolve the acidotic state. And in fact, bicarbonate may worsen hypokalemia, and that's the reason why we avoid it. Okay, so we could eliminate letter D, right? We never give bicarbonate. Now, which one, what would happen to your potassium of 3.3 if you give insulin? What would happen to your potassium if you give insulin?
It goes down.
Yes, and that is the reason why you would not want to do that. Letter C is going to, letter A is going to be incorrect. You're going to kill the patient. All right. So the correct answer is letter C. Administer 40 MEQs. You remember, always correct the potassium first before you give insulin, because potassium is going to go down if you give insulin. All right. Is that clear? Please remember that. Okay. Potassium first before insulin. And the fact that this potassium level is 3.3 is already low. If you give the potassium, if you give the insulin, your potassium is going to go to 2.0 or 3.0. The patient will die from cardiac arrest. Okay. All right. So I told you that cerebral edema is a serious complication that may evolve at any time during the treatment of diabetic ketoacidosis. And this is more profound actually in children. It is the leading cause of death associated with DKA in children. So be extremely cautious to avoid cerebral edema during therapy. And therefore, it is important for you to monitor the neurological signs of the patient, along with your monitoring of their electrolytes, because this is a deadly major complication. So, what are some of the manifestations that the patient is experiencing cerebral edema? Well, change in the level of consciousness, posturing, either decorticate posturing or decorticate posturing or decerebrate posturing, and abnormal respiratory patterns such as Biot's respirations or deceleration of the heart rate or a decrease in your pulse rate. So always remember that these are signs, neurological signs, might be a manifestation of cerebral edema. When that happens, we usually treat the patient with mannitol, because you remember mannitol is a hypertonic solution. So if you remember my illustration over here with hypertonic solution, so if this is the brain cell, and now you give mannitol, and mannitol has a lot of particles. The water from the brain is going to come over to the vascular bed as a result of the administration of mannitol. So mannitol is known as an osmotic diuretic, and the reason why it induces diuresis is because it pulls water from the cells because it is much more concentrated than the contents of the cell. Okay, so actually you got that correctly. So I think I emphasized that the prevention of hypokalemia is the correct answer. Uh, the other electrolytes should be corrected as needed, but if the serum potassium is not monitored and replaced as needed, well, life-threatening hypokalemia may develop, and the complication that is associated with severe hypokalemia is cardiac arrest. All right, we have gone an hour already. Oh my God, I thought we're having fun, I guess. So let's go ahead and take a 5-minute break, and then we'll come back after 5 minutes. Hmm. Okay. So 5 minutes is up. I hope that you're back. So let's continue with another question. Are you all back?
I'm here. I'm just thinking.
Great. Okay. Okay, I tricked you with this one. All right. So the difference between diabetic ketoacidosis and the other complication, which we will be discussing next, HHS, which is hyperglycemic hyperosmolar syndrome, is going to be the blood glucose levels. In diabetic ketoacidosis, the rise in their blood sugar is rarely above 400. But whenever the blood glucose is so high, and the highest that I have seen is 950, for example, that would be in HHS, or hyperglycemic hyperosmolar syndrome. So the correct answer here is letter A. Extreme hyperglycemia with blood glucose above 600 would be a diagnosis of the other complication, which we will be talking about next, which is HHS, or hyperglycemic hyperosmolar syndrome. Okay, let's go to another one. Okay, this is a trick question which you might find in NCLEX, all right? So it says a client with diabetes mellitus arrives at the hospital with a blood glucose of 639. So normally this would not be DKA, okay? But the question says, which assessment data will the nurse report as supporting diabetic ketoacidosis? So this is the good thing. You're not going to argue with the NCLEX people and say, but if it's 639, that could not be DKA. It has to be HHS. But they're asking you, if this is 639, what would clue you if the diagnosis is going to, or support a diagnosis of ketoacidosis? Well, the word ketoacidosis means to say that there's going to be ketone in the blood. And that is the reason why, oh, sorry about that. That is why the correct answer is letter A. Okay? So always answer it on the basis of what you see in the question, because they're asking you what supports ketoacidosis. Ketoacidosis is the presence of ketones in the blood, and ketonuria is the presence of ketones in the urine.
That question was
Sure.
select all that applies.
Um, Was that select all that apply?
Yeah.
A client with diabetes mellitus arrives at the hospital with a blood glucose level of 639. Which assessment data will the nurse report as supporting that? Okay, yeah. I see. Okay. So urinary retention would not be present, right? Kussmol's would be present. I'm getting old. I didn't even read that. That's select all that apply. Okay, so letter A is correct. Where are you, Pen? Kussmol's is classic for diabetic ketoacidosis, acidosis, because it's ketoacidosis. This would be incorrect. It would be polyuria, isn't it? And then elevated blood pressure. Well, the elevated blood pressure is questionable because it should cause hypotension as a result of the polyuria. So this would also be incorrect. So it usually would be hypotension and circulatory collapse. Thank you so much, Lindsay, for reminding me. All right, let's go to the next one. Is this? Okay. So let me just. Okay, and the others? All right, so there's one key thing that I wanted to emphasize over here, and I'm going to write it in the question itself because I want you to remember. When sick, the requirements for insulin increases. Illness causes stress, elevates blood glucose. So need more insulin when sick. Okay, so I always have to do this because a lot of students always think that when you're sick, you should have lesser need for insulin. But because of the increase in the metabolic activity, you need to fuel that metabolic activity with insulin. And that is why the correct answer here is what? It says, demonstrates he understood your teaching. That means to say that letter D is the correct response. Ketone is expected. No, it should not be expected. It is normal for my blood sugar to be 250 to 300 milligrams while I'm sick. It is not going to be normal, so you have to increase insulin. I will hold off taking insulin while I'm sick. That also is going to be incorrect. Okay, so that is it. Now, that was supposed to be our 5-minute break, but we were earlier than that. So now let's go to the other complication of diabetic ketoacidosis, and that is hyperosmolar hyperglycemic syndrome. This is one of two serious metabolic derangements that occur in patients who have diabetes mellitus. Like DKA, it is a life-threatening emergency, although it's less common than diabetic ketoacidosis. It actually has a higher mortality rate. Okay, so if you're looking at deadly, HHS is deadlier than DKA. Right. So there are so many names of this particular state, and that includes your non-ketotic, hyperosmolar coma, hyperglycemic, hyperosmolar, non-ketotic acidosis, and so on. But the term that we agree in now is HHS, which is hyperosmolar, hyperglycemic syndrome. So it's a collection of symptoms. Syndrome is a collection of symptoms. So what exactly is happening whenever we have hyperosmolar, hyperglycemic syndrome? Okay. So whenever we have a patient with, again, I'm going to write. All right, whenever we have a patient with diabetes and there's a lot of glucose in their blood vessels, so glucose, 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 what is now going to happen to the fluid? So this is the cell, and there is a lot of fluid in this cell. What is going to happen to this fluid? It's going to be migrating to the vascular bed, okay? So the state we're in, there's a lot of glucose over here, is hyperglycemic or hyperglycemia. And the state that there's a lot of particles in here is what is known as hyperosmolar. And this results in the problems that are going to be experienced, but there is no ketones that is going to be produced. Why is there no ketones produced in this particular state? Because the patient still has some insulin. He is able to produce some insulin, and therefore the movement of metabolic activity still could utilize glucose, and then the release of carbon dioxide and water and heat as byproducts of metabolic activity. So remember, in patients with diabetic ketoacidosis, they did not have the ability to utilize glucose because there was no insulin. And therefore, because there was no glucose in DKA that could be utilized, they now break down fats because you would need insulin to utilize glucose. So fats are going to be utilized, and the offshoot of fat metabolism is ketones. So that's the difference between the two. So in diabetic ketoacidosis, ketones are produced. The reason is there's still some insulin that could fuel metabolic activity. In HHS, what happens is, in diabetic ketoacidosis, is there's no insulin to fuel it. And so the body has to look for other sources of energy. And the other source for energy is using fat in order to burn for metabolic activity. But the bad thing about that, when you utilize fat, is that you will have the production of ketones. I don't know if you ever have been on a diet, and I have tried dieting and I'm never successful, but if you diet and you test your urine is going to be positive for ketones. And the reason is you are utilizing fat for energy. Okay? So that is just to explain the difference between the two. All right. So when you have HHS, what's going to happen is you will have hyperglycemia, and typically the blood glucose levels of patients with HHS is going to be higher, usually around 600 milligrams per deciliter or higher, right over here. They have hyperglycemia that would result in diuresis the same way that we had mentioned in diabetic ketoacidosis, which therefore results in dehydration as well as electrolyte abnormalities. Okay, so in HHS, there is no ketones produced, but the blood glucose levels are extremely high, usually above 600 milligrams per deciliter. Okay, all right, so let's take a look at this poll. Okay, so let's take a look at the question over here. All right, so when you're taking the exam, always make sure that you look at the keywords. So the nurse is caring for a client diagnosed with hyperglycemic, hyperosmolar state, knows that the client's elevated serum osmolarity has pulled water out of the brain. Has pulled water out of the brain. You remember that complication that I told you? If you rapidly correct the blood sugar, what happens is that you're going to, you're going to cause swelling. But over here, it says pulled water out of the brain, meaning to say they're looking for neurological signs. So weakness on one side of the body is a neurological sign. So this is going to be correct. Body shakes rapidly and uncontrollably, which means to say that this might be a seizure. That is going to be correct. Increase in urine output in proportion to the increase in blood glucose. Well, this is not a neurological sign. And letter D is also a neurological sign. And letter E, pill rolling, is not a sign of increase intracranial pressure or decrease intracranial pressure, but rather this is a classic sign of Parkinson's disease. And therefore, it's not going to be something that you would note as a neurological sign in patients with with HHS or hyperglycemic hyperosmolar syndrome. Okay, so those are the correct responses. All right, moving further, let's take a look at the difference between diabetic ketoacidosis and HHS. So let's take a look at this particular part of the slide. DKA evolves rapidly. HHS develops over several days, and the signs and symptoms of hyperglycemia are going to be polyuria, polydipsia, weight loss, and volume depletion, and the presence of neurological symptoms. Lethargy, focal signs and or seizures, obtundation, and coma. So let me go back again and explain why it is that we have a pulling out of fluid away from the brain. So if this were the blood vessel again, and you have a lot of glucose, and this is the brain cell right here, what's going to happen when you have a very, very high glucose content is the water is going to come over here to the blood vessel. So you are dehydrating the brain. Thus, because of the increase, a lot of glucose in the blood vessel, you are going to cause neurological symptoms of brain crenation. Crenation is when you dehydrate the brain cells. This is going to happen. Okay, so that is the explanation of what we were talking about as far as the neurological symptoms that are associated with patients who have HHS. Notice that in DKA, you seldom have neurological manifestations. So your signs and symptoms will be classic for acidosis. So Kussmaul's respirations, abdominal pain, nausea, vomiting, acetone breath, and dehydration. So those are the major differences and similarities.
I have a question.
Sure, go ahead.
So for DKA, I'm not sure if I heard you. So there's no polydipsia in DKA?
Yes, both of them have polydipsia.
Okay. No, I was just making sure because I was looking at the chart, so it kind of confused me. That's right.
Yeah, there's going to be signs also of polydipsia, but it's much more with HHS. And the reason why it's much more in HHS is the blood glucose is more elevated in HHS than DKA. Okay. So you will see more classic dehydration symptoms, particularly from the brain. Okay. All right. So let's look at this other thing right over here. In DKA, there is absolute or near absolute insulin deficiency, which results in severe hypoglycemia. Hyperglycemia should be ketone body production and systemic acidosis. And again, it develops over 1 to 2 days, and the most common in type 1 diabetes. In HHS, it's much more common in type 2 diabetes. All right, let's take a look at the differences as far as laboratories is concerned. And the most important thing is that you're going to have a greater degree of elevation of plasma glucose in HHNS. Both of them will result in acidosis, but the acidosis is going to be much more intense in diabetic ketoacidosis. That's why it's called acidosis. So where is acidosis more severe, DKA or HHS? It's going to be much more severe in patients with DKA. All right. And as you notice over here, in HHNS, they might have ketones, but remember the magic number 5%? Okay, so it's very, very minimal. And then for the anion gap is much more severe in diabetic ketoacidosis.
I have a question. So how do you correct the bicarb? I know you say you don't give bicarb.
No, we don't give bicarb. We correct the acidosis by merely giving insulin.
So the bicarb, once you give the insulin, the bicarb will get back to normal.
Correct. The acidosis will correct itself. Right. When you give bicarb, the problem is you're going to push potassium back into the cell. And so we're going to have a problem again with potassium. And that's why we don't give bicarbonate. Okay. So do you remember what I said, by the way? Let me just digress here a little bit. When you have acidosis, if this is your cell, and potassium is usually the more abundant, what do you call that, electrolyte in the cell, intracellular compartment. When you have a lot of acids, so these are acids, hydrogen is going to go in. But the problem is hydrogen does not like to have any partner. And so it will throw this potassium out here. So you will now have a lot of potassium in the vascular space. So acidosis causes potassium increase in the vascular space. Now, when you give bicarb, what's going to happen? You're now going to kick out this hydrogen out, and therefore potassium is going to go in. And thus you will have hypokalemia. Do you understand that? Okay.
Yes.
Great. All right. So let's go to this question right here. All right, this is a difficult question and it entails a lot of analysis. All right, so when we have an infection, we're going to predispose ourselves to hyperglycemia, and it might either be DKA or HHS, right? So this infection can cause DKA or HHS, both of them. But the fact that this patient is not taking the metformin regularly, so what happens to their blood sugar? It's gradually increasing and increasing and increasing. And therefore, what's going to happen is that you probably will have a higher degree of hyperglycemia. So the correct answer here is letter A, unfortunately. And the reason for that is because of the fact that he's not taking the metformin regularly. This increases his blood sugar, and therefore this is going to be gradual. And you remember the difference between DKA and HHS. In DKA, it evolves rapidly, and in HHS, it develops over several days. Okay, so that's a little bit of a challenge question. All right, let's take a look at another one. Okay, so the correct answers here are B, D, and E. So let's reason that out or rationalize why those are the answers. My pen doesn't seem to cooperate. All right, so a client is diagnosed with HHS. Which factors contribute to severe hyperglycemia that precipitates HHS? Whenever you have a partial or relative insulin deficiency, you reduce glucose while inducing hyperglucagonemia. Glucagon is stored glucose. Good God. So when we eat, we spend the food that we eat for energy, and the other ones are stored, and they're stored mainly in the liver and muscles in the form of glucagon. Okay. So what contributes to the severe hyperglycemia that precipitates HHS? The reason why the blood sugar is so high is because of the fact that glucagon is going to be broken down, and therefore it's going to result in higher blood glucose levels. And the way in which you look for other sources of energy, such as breaking down glycogen that is going to be released from the liver. By the way, glucagon is released by the alpha cells of the islets of Langerhans. If you remember that, the beta cells secrete insulin, and the alpha cells secrete glucagon. So because of the secretion of glucagon, you're going to have a lot of blood glucose. And then, of course, insulin deficiency. So when you have these three things that are happening, what's going to happen is you will have severe hyperglycemia. Okay, so let's finish with the signs and symptoms associated with HHS. Yes, you have polydipsia. Yes, you have polyuria. But one thing that is unique is the neurological changes. You will also have nausea, vomiting, weakness, seizures, and other signs of dehydration, such as a dry skin, for example, dry mucous membranes, or hypovolemia or hypotension are all signs of dehydration. So this is going to be some more of the signs and symptoms that are associated with HHS. Aren't you glad Fabiola asked that question? All right. So the correct answer is letter C, bicarbonate. I already explained why that is, right? Okay. So All right, because of the administration of fluids on these patients, the risk is that we're going to create cerebral edema. So this is the more acute of this condition. You remember that it differentiates DKA from HHS. HHS always involves the possibility of neurological symptoms and neurological pathology. So cerebral edema would be one complication as water moves back into the brain cells when we're treating this patient. So it leads us to the treatment of patients with HHS. It's basically the same as DKA. So it includes the treatment with fluids as well as correction of potassium, as well as the correction of the acidosis. Remember that in acidosis, we're not going to use sodium bicarbonate. All right, you're all very good. The correct answer is letter D. The key word there is the blood glucose of 600 milligrams per deciliter. That is really very high. So it points to the possibility, or it favors HHS more so than it favors DKA. Wow. Up, I'm going back. All right. Hmm. All right, I put this question here so that I will not forget to discuss it. But the correct answer is letter C, both A and B. And I wanted to tell you that these medications, beta blockers as well as diuretics, they inhibit insulin secretion. And that is why we have to be very cautious, actually, with the use of thiazide diuretics in particular. So I wanted to emphasize that thiazide diuretics and beta blockers are both going to decrease the secretion of insulin. So they would predispose a patient to these complications of diabetes. Hmm. 51. Is the poll showing? Are you seeing the poll?
No.
Yeah, if it is not
Had
letting
it
me.
up for the last question and then closed it out. So I don't know if that closed the poll out.
I did close the other poll, but this one is not opening. Okay. So anyway, we'll just go ahead and answer it this way. So Hyperglycemic, hyperosmolar non-ketotic syndrome would have all of the following signs and symptoms except. All right. So would we have dry mucous membranes? We'll just answer it together. Would we have dry mucous membranes? Yes or no? Yes, because you remember
Yes.
we have dehydration. All right. Would we have polyuria?
Yes.
Yes. And would we have a blood glucose above 600? Yes. But Kussmaul's breathing is an effort by the body to get rid of acids. So you remember that Kussmaul's breathing is an exaggeration of the expiratory phase. So the patient is going to try to blow off the excess acids by blowing off carbon dioxide. So Kussmaul's breathing is found in DKA due to the compensatory mechanism of the respiratory system to eliminate your carbon dioxide and therefore decreasing your acids. Okay? All right. So electrolyte correction is also going to be the same as DKA. So let's take a look at the case study. And the case study shows us that this is a 73-year-old male with a history of type 2 diabetes, presents to the emergency room due to a change in mental status. At 12 o'clock, these are the notes. The 73-year-old male with a history of type 2 brought to the ED by spouse for changes in mental status from his baseline. The wife reports that he woke up 6 o'clock to complete his morning routine. At 11 o'clock, he became unaware of his surroundings and began sweating profusely and slurring words. Breath sounds are clear, but noted with a fruity citrus odor. And deep, rapid respirations. Sinus tachycardia per cardiac monitor. He's awake, alert, pupils equal and reactive to light, and vital signs are respiratory rate of 32, the BP is okay, and pulse oximeter 89 on room air. He is on empagliflozin, 10 milligrams, sitagliptin, and metformin, as well as valsartan. So, which findings are going to be the most significant? Which 4 findings are the most significant? So let's take a look at what those findings are. So you only need 4. Is the poll showing?
Yes.
Okay. Oh, you are all so good. Okay, I think that all right, so when you get these questions in the NCLEX, in the case studies, and question number 1, they're trying to elicit whether or not you can come up with a diagnosis, okay, and collect the symptoms. So in looking at these symptoms that you see now, what are you thinking of? That the patient might have DKA, right? Because of the change in the mental status, as well as the fact that he has a history of diabetes. And then, of course, because of the fact that his respiratory status is showing that he is breathing fast. right? And so the correct answers here are history of type 2 diabetes, as well as the respiratory status. Let me just, and I think most of you got this correctly. So history of type 2 diabetes, the respiratory status, the circulation, and the mental status change. And this would be the important thing. So because he has a history of type 2, the nurse should follow with the signs that the client's diabetes may be out of control. And this could be manifested by the deep and rapid respirations, the odor of the breath, and mental changes.
I have a question.
Yeah, go ahead.
For circulation,
yeah,
where does it say anything about circulation?
All right. So the low BP and the tachycardia, the 118. What is 118 reflective of? Tachycardia is a sign of what?
Low circulation?
Yes. Dehydration. It is a sign of dehydration. So the low blood pressure, along with the tachycardia, is going to be a sign of dehydration. So think about it now, because you should have suspected right away DKA. And if it's going to be DKA, then you're going to have dehydration, right? And so where's the dehydration over here? The dehydration is the pulse rate as well as the low blood pressure. All right. So the object of question number 1 is always to ask you to identify what kind of diagnosis are you framing in your mind. So you're grouping them together. All right. So the lung sounds are not going to be appropriate. The pupils are not going to be appropriate. The medications already, you have the history of type 2 diabetes. All right. So it doesn't help you with it. Okay. So do you get that now? Was that Fabiola or was that Lindsay that asked the question? I'm sorry, I didn't see.
It was Lindsay.
Okay, Lindsay, do you understand now? So dehydration is always manifested by tachycardia and low blood pressure, hypovolemia.
Yes, thank you.
Yes, you're welcome. All right. So now the nurse starts an IV and reviews the labs. For each finding, click to specify if it is consistent with ketoacidosis or HHS. Each finding may support more than one condition. Each column must have at least one correct option. Okay, so I cannot do this on the poll. So as far as the pH, acidosis, do we have acidosis in patients with ketoacidosis?
Yes.
Yes, that's why it's ketoacidosis. And do you remember that we do not have this problem in hyperglycemic hyperosmolar syndrome? All right, the blood glucose. This is going to, the blood glucose, what was the blood glucose again? It is 435. So is this more supportive of ketoacidosis or hyperglycemic hyperosmolar syndrome?
Ketoacidosis.
Yes, over here would be over 600, right? Okay, good. And the serum creatinine, both of them could have a this serum creatinine because of the dehydration. You remember when you are dehydrated, these are the things that happens. Okay, so dehydration would cause a decrease in blood pressure, would increase your heart rate for compensatory mechanisms. It will also alter your BUN, elevate your BUN, and elevate your creatinine. Look at the creatinine. It's elevated 1.9. Could this be only as a result of DKA or HHS? Is there dehydration in both of them? Both of them, right? Okay. So therefore, this would be much more consistent with both of them, ketoacidosis and hyperglycemic hyperosmolar syndrome. And then for the urine, what about the urine? I can't remember. Oh, here, positive for ketones, right there. So would you have that in ketoacidosis?
Yes,
Would you have it in HHS?
maybe.
No, right? That's the one that differentiates it. So this one is going to be no. So the urine is going to be positive for ketones in ketoacidosis. All right, let's go to the next question. So at 12:15, he voided 30 mLs of dark amber urine, sent for urinalysis, comprehensive metabolic panel CBC and ABG, IV started, 2 liters O2 started per nasal cannula. The capillary glucose is now 440. Okay. Complete the sentence. The problem the nurse should address first is correcting the pH, restoring volume, or C, lowering the glucose. Do you remember the acronym? So what would be the correct answer?
E?
B, restoring the volume. Okay, we always treat the dehydration first. Excellent. So letter B is the correct response. All right. So the client is now diagnosed with ketoacidosis and the nurse begins the plan of care. All right. For each nursing intervention, click to specify whether the intervention is indicated, contraindicated, or non-essential. All right. So should we obtain glycosylated hemoglobin? Is this indicated, contraindicated, which means to say this would be dangerous, non-essential, not important at this time? That's
Not
why.
important.
Yes, because glycosylated hemoglobin A1C is going to reflect the 120-day glucose control. We don't need to address that at this point, right? Okay. How about teach the client pursed lip breathing? Is this going to be useful? Do you want the patient to blow off carbon dioxide?
No.
Yes, because they're in acidosis. So this would be indicated. You want that, all right? So pursed lip breathing will help also with slowing down the pace of breathing. How about administering insulin glargine subcutaneously?
Contraindicated.
Correct. This would be contraindicated because what we need is regular insulin, right? Okay. So treatment for DKA is with regular insulin, not with glargine, because it can be given IV and titrated to slowly achieve the goals. All right. So what type of insulin is glargine, by the way? It's a long-acting insulin. It usually is given once daily. How about inserting the Foley catheter?
Not essential.
You remember that we now have what do you call the bundle that we should not unnecessarily catheterize the patients. So over here, it is not going to, it's not going to be good practice to routinely catheterize the patient. So you don't want to do that. So the COUT bundle emphasizes that we should only insert catheters if really essential or necessary. Okay. And how about administering IV potassium? Would it be indicated or not indicated? And the potassium is 3.4.
Indicated?
Yes, we would indicate it. And how about monitoring for ECG?
Indicated?
Why is that? The potassium Hypokalemia, so low potassium levels, increases arrhythmias. And therefore, it is essential that we monitor for arrhythmias. Okay. So question number 5, there are now several orders over here. You review the orders, admit to ICU, give 1,000 IV normal saline, then start with 0.9 normal saline, start regular insulin, and finger stick blood glucose, obtain electrolytes, continuous cardiac monitoring. Okay, so this is question number 5. Okay. Letter A is incorrect. And do you remember why letter A is incorrect? We would not do this.
Because you have to do the potassium first.
Yes, very good. Excellent. I love it. Okay. So you want to correct the potassium first before you give insulin, because otherwise you're going to kill the patient. So you anticipate holding insulin for low potassium levels. Now, request IV fluids. This would also be very, very good, and allow the client to eat when status stabilizes. You know, the patient can eat when the respiratory status is stable and they feel like eating. So this is going to be okay. And monitor for symptoms of fluid overload. This is also going to be okay. Okay, so let's go now to the next question and the 6th question. So the nurse reassesses the client after giving a fluid bolus and starting the insulin infusion. Which findings indicate the treatment plan has been effective? Select all that apply. So the blood pressure is now, do you see the, I should not have. I'm going to end the poll so that we can see the comparisons. Okay, the BP is on top. Do you see it? Originally at 12 o'clock, it's 97/66. And now it is 109/70. So is this an improvement?
Yes.
Yes. Okay. The mental status. Okay. So you remember that when he came in, he was slurring the words. At 12:15, at 13:30, he's now awake, alert, and oriented. So does that mean to say he's better?
Yes.
Yes. And the breath sounds. The breath sounds are clear in the beginning, right here. And over here, breath sounds are clear. So does that mean to say that it has been effective? Well, there's no change, right? So that would not be a manifestation of improvement. How about the pulse rate? The pulse rate is here, 118, 115, 105, and 100. Is that good? Is that a reflection that it is normalizing?
Yes.
Yes. Okay. Because you remember that normal pulse rate is 60 to 100. Okay. And the capillary glucose. The glucose was 435 at 1330. And let's see. There was no other thing.
440. It's at the top.
Okay. Yeah, right here, 440. And it's now 435. Does that reflect that the patient is doing well? It's still very high, isn't it?
Yeah.
440 and 435. So that might not be a good thing to say that this is going to be an improvement. And then, of course, pain levels. I don't think there was any mention of pain at all. So the correct answers are A, B, and D. All right. So, ladies, that is the end of my presentation. I hope that you had learned something about DKA and HHS. And the reason why I'm going back to the slides over here is I wanted to show you where you could go to that link to answer the, there you go, the case study once more. Okay. And by the way, I really would appreciate it if you would send the evaluation. I sent you a link so that I could submit that to the dean. All right.
Did you send the link yesterday?
On an email and yesterday. Yes, correct.
Okay, I have to double check that.
Would you? Yeah, I appreciate it very much. So I will see you. I think today's Thursday. Yeah, I'll see you on Tuesday, right?
So yeah.
Yeah, Tuesday,
Yeah.
Wednesday, Thursday, because I have conflicts on Monday and Friday, and that's why I can't teach on Monday and Friday. So I will see you then. Have a great weekend. It's been a pleasure having you. And thank you, Fabiola, Rachel, and Lindsay. You have a great week. Okay.
Thank you, you too.
Well, I have a question.
I have a
Sure.
question as well.
I wanted to know where I could access the recordings.
Yeah. Okay. So the recordings, maybe what I could do is send it to you. No, I'll post it in my YouTube channel. Okay. So my YouTube channel is just look for Tom Madayag and look for the topics. So we have had 3 topics so far. The first one was on MI and ACS. The second one was on sepsis and ARDS. And this one today. Okay, Rachel? So go to my YouTube channel, and my YouTube channel again is Tom Madayag. Just look for my name, and it should go in there. So give me until tonight to post it. All right.
Okay.
Also, the link for yesterday of the activity, I exited out before I could get the link for the activity.
The activity. Okay, sure. So yeah, let me see. I can give that to you right now if you have time. Just hold on one moment. Sure. And so that we don't have to, you don't have to go back. So, Rachel, do you also need the link to the case study?
Yes, I would like that. I saw the one for the first class, but I didn't see one for the second.
Okay, sure. All right. So the one for yesterday, I'm going to post it now in the chat box.
Also, what is the topic for Tuesday?
Hold on. Let me just finish this one first.
Oh, sorry.
That's okay. That's okay. I wanna say that the topic for next week is going to be heart failure. Okay, so that was the one for yesterday. Okay, the case study for yesterday. That's what you needed, right? Did you get it?
Yes.
Okay, all right. So I will post the videos on YouTube, and you will see the same titles, okay?
For the evaluation of the class, that's in an email?
Yeah, let me give that to you now too, so that you can go ahead and fill that out if you don't mind.
Yeah, I can't find the email.
Yeah, so here it is. Okay, that's the evaluation. I would really appreciate it very much. Did you get it?
Yes.
All right. So ladies, thank you so much. I hope that you come back on Tuesday. I will see you, and have a great weekend. Okay?
Thank you.
You too.
Sure.
Thank you, you too.
Bye-bye.
Bye-bye.
Take care.